So this is the clinical short case. You're asked to anaesthetise a 19-year-old man presenting with a fractured mandible for open reduction and internal fixation. Describe how you'd approach this case.
So I'd like to review this patient preoperatively and I'd perform a full anaesthetic assessment. So I would take an anaesthetic history and a medical history. I'd like to know about the mechanism of injury. In particular, I'm thinking about issues with other external injuries, such as brain injury or C-spine injury. I also want to establish whether they were intoxicated around the time of injury or afterwards. I know that there is potential for difficult airway in these cases, so I would, with my anaesthetic assessment, perform a full airway assessment also.
He alleges he was assaulted in the pub 8 hours ago and was briefly knocked out.
In this case, I'd be worried that that might be evidence of a brain injury. So I'd like to ask him a few more questions. I'd ask him whether he has a headache, whether he has blurred vision, if he's been vomiting or any nausea, whether he's had any retrograde amnesia, and if there are any features of this, I'd want to investigate him further with some imaging.
Okay. Carry on about your assessment of this patient at the minute.
So, in my anaesthetic assessment, I'd ask him about previous general anaesthesia and any problems associated with it. I'd want to know about his fasting time, whether he'd been intoxicated around the time of injury. I'd also bear in mind that there's potential for a difficult airway, so I'd do an airway assessment also.
What would you be looking for in your assessment of the airway?
So in my experience, usually people with fractured mandible have pain limiting their mouth opening. So mouth opening might be limited. If I could assess it, I would assess the Mallampati score, thyromental distance. I would look for any other evidence of dental damage. I'd assess the patient's neck movements, neck mobility. I'd want to have a look at the patient generally to look at the body habitus and look for facial hair also.
Okay, anything else about the assessment of the patient and your anaesthetic management?
I would be considering nasal intubation for the intraoperative period, in which case I'd want to rule out any evidence of facial fractures or basal skull fracture also.
Okay. When would you want to anaesthetise the patient? When will he be ready for surgery?
So again, in my experience, fractured mandible operations don't generally tend to be an emergency. I'd want the patient to be adequately starved. I'd like for them not to be intoxicated when I anaesthetise them. I would discuss with the surgeons about timing of the surgery also, bearing in mind that within 12 or 24 hours after the time of injury, there is an increased incidence of bacterial infection. So I'd want the procedure to be done within 24 hours of injury.
Okay. Describe your anaesthetic plan for this patient.
So I would perform a standard IV induction in the patient with nasal intubation.
Let me just stop you. Would you consider any form of pre-med for the patient?
You could pre-medicate them if you're worried about starvation times in particular, or history of reflux, for example. So you could give them gastric motility medications like metoclopramide and antacids like ranitidine preoperatively. Okay.
And what determines your choice of technique here? What further information do you need?
I'd have a frank discussion with the surgeons about what exactly they're going to do. Usually with an ORIF of a mandible, the surgeon requires access in the mouth to their operative site. So that will determine me intubating nasally to allow them access to the mouth. And the other issue is that although it may seem like they have a difficult airway, in my experience, usually when they've had their induction, their mouth opening isn't limited because the element of pain is taken away.
Okay, so even if the patient has moderate swelling and opens the mouth only 3 finger breadths, how would you think you would anaesthetise the patient and maintain an airway?
So I have to bear in mind that there is potential for a difficult airway. If there is swelling, I would consider an awake fibre optic intubation. you might be able to perform a inhalational induction, although that would be limited by pain on application of the mask. But routinely, I do give them a straightforward IV induction because the element of discomfort limits the mouth opening. Once they've had their anaesthetic, they do tend to open their mouth relatively well, and difficult airway, it doesn't occur as often as you'd imagine.
Okay, so talk me through the rest of the anaesthetic.
So the induction would be a balanced anaesthetic technique. I would maintain anaesthesia with an inhalational agent. I would paralyse the patient for intubation and maintain paralysis because I'd want to intermittently positive pressure ventilate them. I would give them multimodal analgesia and appropriate antiemetic prophylaxis also.
How long is this procedure likely to take?
It could last from about an hour and a half onwards. Generally they can be quite lengthy procedures.
Are there any other issues towards the end of the case? How would you extubate the patient?
With open reductions and internal fixations, there is a risk of bleeding into the mouth and oral cavity. So at times, after discussion with the surgeons, one can place their throat pack. So prior to extubation, you want to remove the throat pack, you want to evacuate any hematoma, and you want to be certain that hemostasis is achieved.
Okay, thank you. On this occasion, the candidate was given a 2 from both examiners. She demonstrated a good understanding of the issues involved in the assessment and management of the patient, including the concerns of the surgeon. She gave a clear plan for the anaesthetic management of the patient, demonstrating that she understood the airway issues which might be of concern. She was able to assimilate the information offered and understood that the airway in this patient was not a difficult airway and that a standard induction and intubation was possible.